Lectures. Today is a great honor to introduce ASHRAF KHARRAT. He's a neonatologist at the Mount Sinai Hospital and works in all three sort of children's hospital over there as a neonatal hemodynamic interested person. And part of her research has been on neonatal septic shock, which is also one of my favorite topics. And so I asked her today to give us some ideas, what her thoughts is about neonatal septic shock and hemodynamic dysfunction. So Ashraf, over to you.
Thank you, Kurt. This is very exciting to talk to your group. So thank you very much for the invitation. I'm going to be, I think, taking about 45-ish minutes for talk and then leaving some time for discussion because I find there's a lot of questions and good discussion that comes out of this topic. I'm going to be talking about neonatal septic shock, focusing on the hemodynamic or the cardiovascular piece. Hopefully, I have no disclosures, and hopefully at the end of this talk, I can share with you a physiology-based framework to help you with your patients who no doubtedly present with septic shock, which is obviously one of the most common complications that we see in the NICU. Neonatal sepsis, very common, and among those, a group of kids with this quote unquote shock. That's the term that we become familiar with. It's also can be synonymous with organ dysfunction, but it's basically the sickest of the sick kids that present with sepsis. In the NICU, we use the term sepsis to basically mean everything from simple bacteremia without a lot of consequences to severe sepsis or end organ dysfunction. We use this term to kind of cover that broad spectrum, unlike our older counterparts. But we're for this talk because it's really those sick kids that develop organ dysfunction that have a high mortality rate. That's the cohort of infants that we're going to focus on. And this is some Canadian data that I'm sharing with you. You would think for all the progress that we've had in neonatology over the last 10, 15, 20 years, that perhaps we would have made a dent into septic shock and septic shock related mortality. But this is our national database, data from our national database. So across thousands and thousands of babies and 33 level 3 NICUs, you can see that the rate of shock among infants with late onset sepsis has, if anything, increased over the last 10 years. And mortality rate among those with sepsis, a late onset sepsis associated shock has also basically increased over the last 10 years. So this problem has not gone away, is not getting any better, and in fact may be getting a little bit worse as we are looking after younger, smaller, more fragile, more immature babies. In adults, they have a really good definition of what shock is. And you'll find I'm kind of dancing around this a little bit because we have no standard definition for shock. There's not a single cutoff of any sort for anything that's used to identify a baby with shock. And adults, they've got this SOFA score, so sequential score that they can use to identify babies. They have clear cutoffs in their international surviving sepsis campaigns for blood pressure cutoff, lactate cutoffs for end organ dysfunction. So it's very easy from a research perspective, from a clinical perspective, to identify this high risk population. But this doesn't exist for us in neonates. We have no blood pressure cutoffs for it's a whole other talk, and we don't have any other clear defined guidelines for how to identify these babies. On top of the fact that the blood pressure data is really hard to work through in newborns, our babies are really heterogeneous. So if you're looking after a 22-weeker and your unit is also looking after term babies, those two babies are entirely different in terms of their baseline physiology. They have different hearts. Their hearts are of different compliance, different abilities to tolerate various loading conditions. Their lungs are different. Their baseline pulmonary vascular resistance, just that, even if you're a 22, 23 weeker, whatever that means, and a 40 weeker that somehow is in the NICU, your pulmonary reserve is different, your neuroendocrine reserve is different, your kidneys function differently. So we cannot compare 22 weekers to 30 weekers to 40 weekers. And that also adds to the difficulty in creating a standardized definition for septic shock. So in the absence of an obvious definition, we go back to physiology. This talk is very physiology focused because we don't have a clinical practice guideline to look after these babies, like to look after preterms and term babies with septic shock. So we have to go back to physiology to understand how to look after the individual baby at the bedside. Okay, this slide is the foundation of the talk in that everything that pertains to hemodynamic presentation starts with the inflammatory response. So when the bloodstream of a baby is invaded with enough of the pathogen that it can actually stimulate an inflammatory response, you get this release of a whole bunch of cytokines and chemokines that work to basically target and recruit leukocytes and other important cells in order to get rid of this foreign invader, be it a bacteria, fungus, or a virus. And all of that is happening within the endothelial system, so within the bloodstream. And of course, because the bloodstream is diffuse, it's happening everywhere in the body. So this endothelial activation is a release of a lot of substances. And you get vasoactive substances, you get a lot of vasodilatory substances, a lot of procoagulant substances. All of these things are happening within the blood vessels. At the same time, the body tries to release some anti-inflammatory cytokines, try to keep that at bay. That doesn't always work. And the body releases a bunch of its own fight or flight hormones, so its own catecholamines, in order to respond appropriately to this pathogen that has invaded. So this is the inflammatory response that happens. And what we see clinically, obviously, we don't see these things on the micro level within the bloodstream, but we see either an excessive amount of catecholamines, which is giving us this vasoconstrictive picture, cool extremities, delayed cap refill time, pulses are weak, blood pressure might be high because the baby is so vasoconstricted. Or we see this very vasodilated, very vasodilatory shock or warm shock. So these babies are warm, they're ruddy, they have flash cap refill time, very brisk cap refill time. Their pulses are bounding, which is essentially a widened pulse pressure, and they're hypotensive because they're vasodilatory. So these are the two classic phenotypes that we see in in septic shock. They're really well described in adults and in peds, and they're increasingly well described in newborns. In adults, the primary hemodynamic presentation is warm shock, and in peds for outpatient pediatric septic shock, it's primarily more of a cold shock picture. And from the data that we have a lot more data over the last 5 years about this, but it looks like newborns as well are presenting with a vasodilatory shock as the most classical presentation. But again, it's not like the baby comes with you with a sign that says I'm warm shock, I'm cold shock. This is really a matter of clinician being at the bedside and examining a baby with sepsis and seeing what type of clinical phenotype they have. And when we use the word shock, we're saying that the ability for the body, that baby's body, to deliver adequate oxygen to the tissue is impaired in this state. So it's probably impaired for two reasons: increased consumption at the tissue level, because we've got these really highly metabolically active tissues that are trying to fight off this infection, and impaired delivery for a whole variety of reasons, which you can see in this schematic, all the different components that go towards oxygen delivery. We can't really affect oxygen consumption so much because a lot of that is happening at the tissue level and even at the mitochondrial level, but we can affect and evaluate the oxygen delivery component. So when we see a baby with shock, there is already a mismatch that's happening, and our job is to address the oxygen delivery to really at least try to optimize that arm of the balance. How can we do that? What are the different clinical parameters that we have? I will talk about echo, of course, because echo is so valuable in this situation, but I really want to impress how important, or even more important, the regular routine tools that we have available to us are in understanding the hemodynamic phenotype. Most sites don't have 24-hour echo. Our sites, we have 5 T&E faculty, or however you want to call us, hemodynamics faculty, but we don't have 24-hour echo. So it's most of the information can be gleaned from really careful assessment of all of these typical parameters that we always have on all of our babies. So we'll start with heart rate. Heart rate's an interesting one because just that initial part of the sepsis, or whatever it is, the symptoms that prompted you to do a septic workup, that release of catecholamines that happens at the start of the inflammatory cascade, that can increase your heart rate. You've certainly seen a tachycardic baby that doesn't evolve into a septic shock situation. It's just tachycardic and then settles down, and that baby remains okay. But you've also likely seen the baby that develops tachycardia as a compensatory response to whatever impending thing is about to happen, usually a low SVR state. So you don't know that at the time of tachycardia, which is why oh, wait, is someone speaking? Okay. You don't know that at the time that you assess or identify the tachycardia, if this baby's tachycardia is just going to settle down or whether this is a compensatory mechanism, which is why it's so important and why it requires very, very close monitoring to how it evolves and to the other hemodynamic parameters. So then we move on to blood pressure. Blood pressure isn't necessarily the first vital sign to derange in these babies, but in neonatology, we spend so much time focusing on blood pressure. And that's often the trigger to initiate interventions is when the babies become hypotensive. But a lot of times things happen before the hypotensive that can give us reason to act. And we'll talk a bit more about that later. Blood pressure actually gives us a lot of information, and if you to one of the big things with my trainees at least is that we do not just talk about mean blood pressure in isolation. Mean blood pressure is a calculated value that's important because it reflects organ perfusion pressure, but in and of itself is not adequate information for what the blood pressure of the baby is. You actually get a lot more if you look at more information if you look at systolic and diastolic blood pressure. So diastolic blood pressure being like the blood pressure that remains in diastole when there's not active blood being ejected out of the heart. That's essentially a good reflection of your vascular resistance, your systemic vascular resistance. So when diastolic blood pressure starts to drop, you can see that that is a SVR state that's starting to SVR that's starting to lower, or a vasodilatory state. Systolic blood pressure is reflecting that maximum cardiac impulse that happens with left ventricular ejection. So systolic blood pressure is the good surrogate for cardiac output. So these are good clinical clues. You don't need an echo for this, but these are good clinical clues to follow when you're looking at the hemodynamic phenotype of these babies. And for the low SVR kids, if you are fortunate to have an invasive blood pressure monitor at the time of their sepsis, or at least you're very, very frequently checking the blood pressures after you've decided the baby might has presumed sepsis, you can see that their diastolic blood pressure will often start to fall before the systolic blood pressure does. So that's basically telling you the SVR is starting to lower and lower and lower. And eventually the cardiac output will start to lower as well. And it's quite an interesting phenomenon. And then you have markers of end organ function. Urine output is really the classic one because it's the first one to go in babies. This is a diving reflex. We see it in a lot of newborn disease states. But renal perfusion is so sensitive and so easily altered. Babies are really good at diverting blood away from the kidneys when they have altered blood flow states. So when the urine output has started to fall in a baby with sepsis, that's already telling you have a blood flow problem. And that warrants urgent attention, even if the kid is not yet hypotensive. We don't necessarily use creatinines for screening in these babies because the creatinine can lag. So we really look at renal function, and the function is production of urine output. Cap refill time can give you a bit of clues like we talked about in terms of cold shock versus warm shock about the hemodynamic assessment, although it doesn't really tell you much about cardiac output, but it can help you decide on which phenotype the baby might have. And we're using NIRS, cerebral NIRS in our unit and a lot of other units to look at the brain as an end organ as well, to tell you whether the brain is receiving adequate oxygen or whether the brain is trying to compensate for inappropriate blood flow. So those are the parameters that we basically have readily available at our bedside. And then there's been some studies over the last few years that have taken a deeper dive into the actual numbers that we get looking after these babies. So the one on the left is one of my colleagues, Dr. Faith Zhu from Sinai in Toronto, and Dr. Shiv Saini's group in India as well they've done similar studies looking at various blood pressure parameters pre-illness, so like 24 hours before the baby had their septic workup, and then within the first 24 to 48 hours after the baby had their septic workup, and found that all three parameters can change in babies with septic shock, but it's really the change in systolic blood pressure that is most associated with mortality. And that makes sense because that's kind of a later finding in these low SVR babies. As we talked about, diastolic hypotension can happen first, but when things really have come far along, then the systolic blood pressure starts to drop, and that's when things are quite bad. And we also did some other work looking at other parameters on a population level in a large group of infants with septic shock. And we found other indices that are related to mortality, looking at hypoxemic respiratory failure, base deficit worse than -8, need for vasopressors and inotropes. So we're starting to identify specific conditions that are associated with mortality on a population level. And then most of you are probably familiar with this being quantified into a scoring system in the ANSOFA score. It's the Jim Wynn's work, where he took 3 different components of sepsis care, quantified them, and then looked at the relationship between the ANSOFA scores and mortality. And there's different cutoffs meaning different things. So this is all very helpful information, certainly when studying babies on the whole or trying to risk stratify groups of infants. But we're still back down to like, how can I use this information for my individual baby at the bedside, the 1 or 2 times I might see this a year? So we're going to go through this cardiovascular system because this is what's happening for our septic shock babies from kind of tip to tail. Remember, a baby in shock has inadequate oxygen delivery for what their oxygen requirements are at the tissue level. And the things that we can best impact at the bedside is oxygen delivery. If we're thinking about oxygen delivery, we have to think about all the different places that oxygen goes before it gets delivered to the tissue. From the ventilator, these kids are probably intubated, from the ventilator through the lungs, to the pulmonary vascular bed, to the heart, to the big, then medium, then small vessels or microvasculature to the tissue. And if you think through that process for your babies that are in shock, and we try to attack each one of them one by one, then hopefully we can help improve overall oxygen delivery at the cellular level. So we're going to talk through these. I'm not going to talk about the lung piece because that's kind of a whole other talk, but focus more on pulmonary vascular disease. We'll talk about cardiac dysfunction, blood flow, and microvascular dysfunction. And I've just numbered the order in which I'm going to talk to them about because they kind of seem to make the most sense to do it this way. So it's not like top to toe, but we're going to start with cardiac dysfunction and systemic blood flow because that's kind of where most of our problems are. So let's step back to warm shock. Remember, we talked about warm shock or vasodilatory shock is the primary hemodynamic phenotype that we see in sepsis. Most babies present with this. So what's the primary problem? Let's work through this. Low SVR state is the primary physiologic problem. When you have vasodilatation, that's affecting your arterial side and your venous side. So you get less venous return back to the right side of the heart because of venodilation. That results in lower pulmonary blood flow, then lower left-sided preload, which impairs left ventricular systolic performance, which then decreases blood flowing out of the left side of the heart, worsening vascular resistance, worsening vasodilatation, further diminished right-sided filling. And then this process kind of goes in circles and gets worse and worse and worse. And these things all contribute to diminished cardiac output and shock. Now, knowing that low SVR is our primary problem, how do we approach management in these kids? This is just a high level overview. We'll talk a bit more about management, but this is your primary problem. So this is the primary thing we have to address with our treatment strategy, with fluids first and then vasopressor second. If the kids are really, really far gone and vasopressors aren't enough, or the baby is quite far advanced into their septic shock journey, then once we get to this point where we actually have cardiac dysfunction, which is either a primary or secondary consequence of the sepsis, then we may need to add inotropy as well to support cardiac performance. But usually for these babies, for these babies, the first line therapy will be vasopressor, because vasopressor will address the underlying physiologic problem, which is low SVR state. Okay. Now let's talk about cold shock, opposite problem. So again, primary problem here is extreme vasoconstriction or high systemic vascular resistance. So now we have a high afterload to the left side of the heart. This affects the way the left ventricular pumps, so it decreases the left ventricular systolic performance. As a result, there's a lower stroke volume coming out of the left side of the heart, which this in and of itself will cause low cardiac output and shock. If you have lower blood volume coming out of the left side of the heart, the filling pressures are increased and it becomes harder to fill the left side of the heart. And that back pressure basically affects the lungs and then worsens as well the forward pressure of systolic performance. And this cycle worsens and worsens and worsens as the SVR is untreated. So these contribute again to low cardiac output and shock, but with a different physiologic mechanism than the warm shock babies or the low SVR state babies. So for these kids, what's the primary problem? High SVR. So what's the approach to therapy? Well, it's a little bit interesting because we're always very careful about using a I-node dilator in the NICU because our babies are so sensitive and so at risk of becoming hypotensive. So instead, we focus primarily this problem, the ventricular dysfunction that happens as a result of left ventricular failure from pumping against a high SVR state. So really, inotropy here is the mainstay of therapy for a high SVR state or cold shock or cold septic shock. Those are that's an overview of how you can think through the physiology of babies, even without an echo. You can clinically tell if the baby has warm shock or cold shock. The echo doesn't tell you that clinical piece. It will tell you what's happening from a heart and filling pressures perspective, but you've already gotten the clinical diagnosis by the assessment. So if you know that the baby's either a low SVR or high SVR state based on your clinical assessment, you can work through that physiology to see how to target your management. This is a really nice schematic from one of the papers from the European group. This is a typical Satien schematic, but I just included this here to draw the attention that what we just talked about in the previous two slides is cardiac dysfunction or cardiac performance problems as a secondary issue related to vascular resistance. But you can also have a primary cardiac problem, primary cardiac dysfunction, depending on the pathogen. Pathogens can directly cause a myocardial injury and cardiac dysfunction. This is less commonly seen in neonates, more commonly seen in older adults. The sepsis cardiomyopathy thing, we don't really see it so much in our preterm babies. So again, still you can work through the physiologies of the two previous slides if you have the bedside assessment of the baby being either cold shock or warm shock. It's a great place to start. So remember, we're thinking through that state. I said we're going to talk about cardiac performance and systemic blood flow first. Then we're going to talk about pulmonary vascular resistance second, thinking about our oxygen delivery. And pulmonary vascular resistance is important because when we think about septic shock babies, we know that they have some degree of oxygenation failure. They're often in 100% oxygen. And we often talk about them having pulmonary hypertension as the diagnosis for them being in 100% oxygen. There's certainly some literature that says kids with sepsis can have pulmonary hypertension. There's just some observational data that shows that septic babies have higher pulmonary pressures than non-septic babies. So that's helpful information. Again, population level data. There's, again, a physiologic rationale for preterm babies having pulmonary hypertension and sepsis. Remember, we talked about the inflammatory response, release of a lot of local vasoactive substances. That includes pro-vasoconstrictive substances like thromboxane, endothelin, and these can increase PVR, so increase pulmonary vascular resistance. So we see animal studies and in vitro studies that have shown that if you have receptor antagonism to these vasoconstrictors, you can normalize pulmonary pressures in septic babies. So there's observational data to support that pulmonary hypertension can happen in sepsis, and there's physiologic rationale for the fact that pulmonary hypertension can happen in sepsis. So we always have to think about these things because they can affect oxygen delivery, of course. But it's a bit more complicated than pulmonary hypertension. This is a whole other talk because these are really complex interactions that are happening. But I want to spend a minute on this slide explaining that the pulmonary vascular disease is more complicated than just regular old pulmonary hypertension. So yes, pulmonary arterial pressure can be increased in sepsis. This will affect oxygen delivery, and this will contribute to shock. But why is pulmonary artery pressure increased in sepsis? That can happen for a whole bunch of reasons. And that's where that clinical kind of thinking through all the different possibilities can help us address these for babies at the bedside. So this is the pulmonary vascular tree. This is the right heart going from the pulmonary artery to the arteriolar system, to the capillary bed, to the venous system, to the left side of the heart. And I do hope you can see my cursor. And all of these different components of the pulmonary vascular tree can be affected during sepsis individually, but usually in a combination of sorts. We've already talked about how cardiac dysfunction can happen in sepsis, either as a consequence of low or as a high SVR state, or directly as a consequence of the bug itself, direct myocardial injury. So we've already talked about that. The inflammatory response that we had, we discussed that schematic of what's happening within the blood vessels, within the endothelial, as a result of the inflammatory cascade. We've talked about release of local vasoconstrictors, microthrombi, that kind of DIC picture. This is happening within the pulmonary arteriolar side, and this can contribute to increased pulmonary vascular resistance. We know that babies don't breathe as well or as efficiently or as effectively when they have sepsis for a variety of reasons. And so they lose their FRC, even transiently, and that can increase their pulmonary vascular resistance, contributing to increased pulmonary pressures. Then if we move toward the capillary bed, we've seen babies that have capillary leak. This is when their endothelial integrity starts to fall apart because of the inflammatory response. And then they get leaking of interstitial fluid, and it becomes more and more difficult to oxygenate. That capillary leak syndrome can happen in our sickest babies. That can contribute to increased pulmonary pressure or worsening oxygenation. ARDS, I'm sure many of you have seen this, where we have secondary surfactant deficiency because of inflammatory mediated surfactant destruction. This can happen, worsening oxygenation, again, affecting oxygen delivery. And then moving into the pulmonary venous system, something we don't talk about a lot, but certainly something that's described in some small studies, including animal studies, that you can have venous destruction in sepsis, inflammatory mediated loss of any type of venous compliance. They become less compliant structures, and that can worsen your oxygen delivery. And then finally, to the left side of the heart, again, that left ventricular systolic and diastolic dysfunction that can happen that we talked about can also worsen your oxygen delivery. So I draw your attention to this slide to say that pulmonary hypertension isn't the be all and end all of oxygenation failure from a pulmonary perspective. There's a lot of different reasons across the entire pulmonary vascular tree that can impair oxygen delivery. And it's our job to think about this whole spectrum of things that can be happening, usually many things happening together, but all of these things can worsen oxygen delivery and worsen shock in our septic babies. And then finally, we're going to move into the microvascular component. This is important because this is actually where oxygen exchange happens. This is it. Everything that we do from a macro level, whether we're talking about inotropy, whether we're talking about affecting your vascular resistance, it's actually to improve oxygen delivery at the microvasculature level. We just can't measure it and we just can't see it. There are some tools in adults that they use to, I think they're only using them for research, but they can look at microvascular function in adults in a bunch of disease states, including sepsis, but we don't really do this in newborns. These are four components for us to think about when we're talking about microvascular function or microvascular dysfunction. What are these four aspects of microvascular state that we need to think about? So the first is driving pressure, which is the upstream pressure, which is blood pressure. We're good at thinking about this in the NICU. We do all the things that we can do to monitor and improve blood pressure, so this is okay. The second is arteriolar tone. Part of this is that SVR state that's mediated by the sepsis phenotype, but this also it is also related to your adrenergic enzyme sensitivity. So all of our arterioles are covered in a whole bunch of catecholamine and other types of receptors, but these receptors become less sensitive in sepsis and even less sensitive in acidotic states. So this is why some of these babies are reliant on exogenous catecholamines because they basically tap out or their own endogenous catecholamines aren't enough for their poorly sensitive receptors during in sepsis. So they might be able to produce enough endogenous norepi and epi if they're in a well state, but when they're not, they quickly need us to supplement it. Then we think about blood flow through the capillary bed, which is really affected during sepsis. The red blood cells start to deform, platelets start to plug. That's part of the inflammatory cascade. And when they do this, they block off some of the capillary network. And so you have like less network for gas exchange. That's another reason why gas exchange can worsen. And we can fix this with fluids. I'll talk about that in a second. And then the capillary status, again, same thing, lower microvascular density during sepsis, partly related to the bug, partly related to the inflammatory cascade, but in essence, less opportunities for gas exchange to happen. So when we're putting this in our minds, like at the bedside, and we're seeing a baby that's sick with shock, we are trying to remember everything that we're doing upstream is to try to help this microvasculature gas exchange happen, because that's how the tissues will reoxygenate and will heal. We often think about impaired oxygen delivery as anaerobic metabolism, rightfully so. And we see lactates, hyperlactatemia as a result of that. And I think in the NICU, where we can be a little casual in a way about high lactates, more so than in adults. Like if you saw in that first slide, the adult cutoff for high lactate was 2 millimoles per liter. Hopefully you guys use the same units. But in newborns, we often get higher than 2, and we don't really sweat too much about it because our babies can tolerate high lactates really, really well, and they can recover from them really well. That is fantastic for babies, but also sometimes makes us a little bit casual when we start to see hyperlactatemia. I use this diagram because I really want to show you what the baby has done before their lactate has started to go up and how hard they've worked to avoid hyperlactatemia in the first place. So this is oxygen consumption on the y-axis, oxygen delivery on the x, and we've got lactate here in red. Let's say for the same oxygen consumption, which isn't what happens, in sepsis, but let's say for the same oxygen consumption, as oxygen delivery worsens, the baby tries to increase its extraction ratio of available oxygen. So it works harder to try to pull whatever little oxygen molecules it have to the tissue. It's increasing extraction ratio, but it reaches a critical threshold where it can no longer extract anymore. And that's when the lactate starts to go up. So for us, when we see a lactate start to elevate, it's actually it should be quite shocking, because the baby has done all this work to increase its extraction ratio to try to avoid hyperlactatemia, avoid anaerobic metabolism. And so I find that I have to remind myself, even though the babies can recover from high lactate states really nicely, that it's quite, the baby has done a lot of work to try to avoid being in this state. So when the lactates start to rise, we're already behind. So let's talk about management. Like, how do we treat this? How do we address the baby with with septic shock? We're now knowing a bit more about what the underlying physiology can be. This is a schematic from adults. Ignore the exact numbers, but the premise is good, that it's salvage, optimization, stabilization, de-escalation. Salvage is you have to work fast to salvage. And our babies don't have reserve. We talked about that at the beginning. They have a very little reserve because of their baseline illness, their baseline cardiac status, pulmonary status, and their own neuroendocrine responses are so easily depleted that they really need us to intervene. So that salvage needs to happen quick. Once we can do that, we can optimize, make minor tweaks. Then we leave the baby alone so that they recover, and then we can start to pull back or de-escalate. So usually our first step would be fluid therapy. A lot of times we talk about fluid therapy as filling the tank, that type of thing. But it's not just about filling the tank, which is how I interpret that saying is basically improving blood pressure, which is improving volume within the macroarterial system. But actually, fluids don't just stay within the aorta and big arteries; they move everywhere. So it's really filling up the entire tank. And also, or more importantly, it's pushing that blood through the microvasculature in order to basically better kind of clear up that platelet plug and those deformed red blood cells that plug up the capillaries. We want to flush them so that we can expand as much opportunity for oxygen exchange to happen at the tissue level as possible. So it's not just about fixing blood pressure. Yes, it is, but it doesn't just stay within the arterial system. We give push boluses because we want to really clear out the microvasculature. Of course, when we give fluid, we want to assess that the cardiovascular system is fluid responsive, i.e., willing to accept and tolerate this fluid and improve with this fluid. And we use the Frank-Starling curve to assess this. So this is the Frank-Starling curve on the bottom. For the same fluid bolus, we want to see if we can really augment stroke volume. That's a fluid responsive baby. This baby, once they're on the flat part of the curve, that same fluid that we gave doesn't really increase the stroke volume all that much. So it's not really a fluid responsive baby. Like it doesn't really do anything for improving the cardiovascular system. The Merrick-Phillips curve actually lines up with the Frank-Starling curve. So you ask yourself, where did that fluid go? Like, if it's not helping to improve the Frank-Starling curve, what's it doing? Well, it's actually worsening the interstitial lung fluid, and because that fluid has to go somewhere. So it worsens interstitial lung fluid, and that impairs oxygen delivery at the tissue, at the interstitial level in the lungs, which makes things worse. So we have to be very mindful with the fluid boluses that we give. We can't just be giving them willy-nilly. We should be assessing fluid responsiveness in some way to help us titrate the amount of fluid for that individual patient. And you guys have started to do this. Kurt's got this study that's looked at mini boluses over 3 mils per kilo over 5 minutes, and using the LVOT VTI or an echo parameter to assess pre and post changes in left ventricular output after fluid boluses. So this is one way to do it. And I know there's more work to be done in this parameter, but in this field. But this is one way to quantify whether the baby's able to actually augment their stroke volume after giving fluid boluses or not, so that we can be sure that we're giving appropriate amount of fluids and not excessive fluids, and fluids to the right baby. After fluids comes vasopressors. I'm talking mostly about vasopressors because, again, most of our babies present with vasodilatory shock or low SVR state. And remember, we talked about if the primary problem is low SVR, we need to increase it with improving SVR. So that's a vasopressor that will do that. What does a vasopressor do? It helps to recruit blood volume within the arteriolar and venous system to improve blood return right back to the right side of the heart. So when we give vasopressors, we do not just target the arteriolar system, of course, because you can't do that. But that's what we measure when we do blood pressure. We will measure arterial response to vasopressors, and they should improve. When we give an optimal dose of a vasopressor, we'll see the blood pressure go up. But that helps with improving tissue perfusion. Remember thinking about the driving pressure for the microvascular system, but it also recruits the venous side as well. And remember, the venous side also dilates in sepsis. This is not just an arterial problem. So when we recruit the venous side, we increase venous venoconstriction, and that helps improve blood back to the right side of the heart, helping improve right-sided preload, then left-sided preload, then left ventricular output. So you're actually making both sides of the vascular system better. And both of those things can help to improve oxygen delivery in sepsis. It's harder to measure the venous side, but on echo, you can actually see that the right side of the heart gets better filled and the left side of the heart gets better filled on a baby with a vasopressor, assuming you've had the optimum dose. Oh. Which vasopressor? Okay, well, data to come. But the good thing is we really only have 3 to choose from: dopamine, norepi, and vasopressin. And I'm not so regimented about this because we still need some data to help us discern through these 3. But I'm going to show you the 2 biggest studies that we have in neonatal septic shock that can guide our therapy. This is the first one and really the OG study in this field. And this was an RCT looking at epinephrine versus dopamine in neonatal septic shock. This was done in India and Shiv Saini's group. They used alpha dosing, epi, and dopamine, and compared these hemodynamic outcomes to babies with septic shock. They didn't really see any difference in these 2 groups. But they did find something interesting, which is in the smaller gestational age babies, there was actually a preference for epinephrine compared to dopamine in terms of hemodynamic stability. And this was a really interesting study because we couldn't answer that in this small group, but there's only 5 babies or so in this group. But why, sorry, there were 9 babies. Why might that be? There were some smaller studies that came after this that showed that really small or really sick preterm babies are not very good at responding to dopamine because they cannot convert dopamine to its active form and act on catecholamine receptors. And you're really just limited to dopamine acting on dopaminergic receptors. Versus epinephrine will just act on catecholamine receptors because it's already that catecholamine that the receptor acts on. So um, that led to some hypotheses. Why not just use a catecholamine like norepi or epi versus using dopamine, which partially has to be converted? This is all, hypotheses being generated and non-provable stuff. But there's certainly some signal coming towards moving away from dopamine and using norepinephrine as a first-line agent. And a lot of that started in adults. And then we looked at this, and this is a study we published a couple years ago, looking at this in newborns. Because remember, I talked about how adults have a very similar hemodynamic presentation to babies. I should say the other way around. Babies have a similar hemodynamic presentation to adults. So it was quite intriguing. We're seeing data that they might not respond to dopamine. Adults certainly have really good data that they don't respond, they don't have as good outcomes when they're dopamine exposed compared to norepi exposure. So we did this study. We looked at about 150 kids with septic shock and compared kids with dopamine versus kids with norepi. Of course, more kids with dopamine at the time, and found that there was lower mortality, a lower risk of among survivors neurodevelopmental impairment, and lower post-illness diagnosis of brain injury in kids exposed to norepinephrine compared to kids exposed to dopamine. So this was the premise for us doing our international trial, which we're doing right now. We're comparing dopamine to norepi, so data to come in a couple of years, hopefully. I'm going to briefly just mention that there's no data on using vasopressins and steroids in septic shock, only physiologic rationale, especially for the steroids piece because of the presumed adrenal insufficiency in this cohort of infants, but no data to actually guide us doing this right now. So in the absence of data, what do we do? Can't really choose the right drug because there's not enough information to tell us. So instead, we think about avoiding choosing the quote unquote wrong drug. I say that very tentatively, but really what I mean is whatever medication you choose, think of its secondary effects or its adverse effects, and can the baby tolerate the adverse effects? So for example, dopamine is a great example. So apart from the limited data that we have that it seems that norepi is better for outcomes in newborns with septic shock, we also know that dopamine can really increase PVR, whereas norepinephrine doesn't really do that. Our babies already have this very tentative PVR at baseline, which can be really worsened in sepsis, as we talked about a few slides ago. So we certainly want to avoid choosing an agent that can increase PVR because we don't want that agent to be the thing that tips them over the edge and worsens oxygen delivery. So that might be another reason why we would choose norepi, for example, over dopamine. So for every circumstance, every hemodynamic situation, think about the primary physiologic problem, think about which drug, either vasopressor or inotrope, that you need, which class of drug, and then think about its primary effect, but it's also secondary effects and whether the baby can tolerate those secondary effects. We put this out together in our unit in this like local clinical practice guideline. And we really basically wanted to tighten the septic shock management and monitoring in our babies. We didn't want to have late diagnoses of hypotension when the baby clinically looks to the nurse really sick. We wanted to be able to be sure that we identified these kids early. So we started with this was inspired by surviving sepsis. But we started with some targets for antibiotic administration within 60 minutes. We did that as a QI project and showed that we improved time to antibiotics significantly. Then we added some monitoring parameters. This was probably a little aggressive. This was the first iteration of this. So a little bit aggressive from the blood work perspective, but not from the blood pressure perspective. So we said that we were going to do this for every baby who had a septic workup, because at that time, you can't really tell who's going to worsen into shock and who's going to be okay and who's going to have a negative culture. So really dedicated monitoring and lots of education to nursing for this so that they knew when to call the physician to come back and reassess. And then if the baby did progress to shock, we gave some parameters for fluids. We've changed this to 10 to 20 mils before starting a vasopressor or an inotrope, depending on what the hemodynamic phenotype is. So most kids are warm shock, so we'll need a vasopressor first line. We use norepi. We use hydrocort as a second line, and then we add vasopressin if we have to. And then for the cold shock kids, like we talked about earlier, we start an inotrope. Epinephrine usually because the babies can't tolerate something like milrinone that can make them hypotensive. So we usually use epinephrine first line. So this has changed our processes for sepsis care in our unit, and all of which have improved frequency of blood pressure monitoring, time to antibiotics, time to diagnosis of shock, that type of thing. I'll just finish this off with a couple echo clips because I like to show these. So when we do TN echo for these babies, we do a full comprehensive TN echo. We do not do like limited scans, but I'm only going to show you a couple clips just to show you really the breadth of echo presentations that we see. This is a pretty classic hyperdynamic heart of vasodilatory or warm shock. This is a baby that ended up with gram-negative sepsis, but has profound low SVR state. So this is a very vasodilated kid, very little preload to the right side of the heart because of venodilation, very little preload to the left side of the heart because of low right-sided preload, and a really snappy heart, partly because of catecholamine response and partly because of the body just trying to compensate for this systemic vasodilation. So really empty, snappy heart. This is the parasternal long axis. Some people refer to this as the kissing walls of the ventricles, but essentially it's reflecting a very, again, hyperdynamic, empty ventricle. And the hyperdynamic piece is a really high ejection fraction. The body's really trying to compensate for low blood pressure by maximizing the amount of blood that it squeezes out of the left ventricle, leaving in the end a pretty empty left ventricle at the end of systole. Same thing that we see. This is a modified RV3 chamber. So you can still see that same snappy heart on the right side. Compare this to a vasoconstrictive shock. This is a baby with late onset GBS sepsis. So high SVR, profoundly high afterload. You get left ventricular failure and then consequently right ventricular failure. This heart is really not squeezing, obviously. So this is a heart that needs inotropy ASAP. We treated this baby with epinephrine. To summarize, really, managing these kids requires kind of four overarching themes. Number one is source control. I don't talk about that in the presentation because it's not like quote unquote hemodynamics, but sepsis management starts with antibiotic therapy, using your local antibiograms to direct it. Think if the mom is colonized with any weird bugs, because if the kid is shocky, you might have to expand your antibiotic profile. And sometimes reviewing the baby's own cultures or the mom's cultures can help you with directing your antibiotics. Second is early recognition. You cannot recognize something if you're not looking for it. Looking for it means knowing you should look for it. So either you, your colleague, or the nurse should be really knowing what type of parameters they should be constantly examining for in these kids. Third is identification of hemodynamic phenotype. You can't treat something if you don't know what it is. So you have to identify, label it as either a vasodilatory or vasoconstrictive shock. And that will guide your therapy, but you can't just treat something if you don't understand the underlying physiology. And then finally, goal directed. So meetings in adults, but for us, it's really trying to end organ function. So recovering hypertension, recovering oliguria, anuria, recovering hyperlactatemia. So those are the parameters we should be constantly evaluating after we've initiated our therapy to make sure that our treatments are working. Thank you very much. I'm happy to take any questions.
Wow, ASHRAF, that was fantastic. Thank you so much for your overview. I think your camera is frozen, but we'll see. Maybe it's just me. Look, this overview started, I think, was a really important message about the epidemiology of septic shock, and most importantly, that there was no reduction in mortality. If anything, maybe there was an increase in mortality. And I think that's really important because we've been treating it the same all the time. We do need to change and find a better way. You did bring and highlight the importance, or actually the lack of a patient-specific definition, which will work for us. But you're still working on it. We're all still working on that. And then you brought us into the physiology and the clinical phenotypes and recognition, clinically, really importantly, and the relationship with certain sort of aspects and mortality, including the NSOFA score. And I'll have some questions about that. And then the beauty of your talk, the pathophysiological approach to warm shock and cold shock, and really highlighting the macro circulation the lungs and the microcirculation as different aspects, and you went to it and even explained to us particularly the aspects, how complex it can be on each individual level. And then last, you ended up with just giving us just physiological concepts about treatments and what would make sense, and with that flow diagram, which must have made that's, to create it and get everybody to go like, well, let's have at least a template to work on and, work our way through that from there. So yeah, thank you very much. There's certainly some questions in the chat box. I'll start with some of them. Alvin has two questions which are related to ultrasound. If you're looking at this warm shock, cold shock, how do you differentiate that using point of care ultrasound? What will be your parameter? Which parameter you look at? You showed us pictures, and that was clear to us, I guess, but is there a certain parameter you can use?
So I don't know what's done in POCUS because we do full TN echoes, but I can tell you from that perspective, we cannot measure vascular resistance by doing echo. We can only presume vascular resistance based on alternative things that we see from a cardiac profile. So with low SVR state, because the baby is preload deficient, they're so vasodilated. We often will see an empty right side, a really small empty right side. And as a consequence, a very small empty left side, with initially high left and right ventricular output. That's that hyperdynamic response. Left untreated, it can start to diminish. So we will see a very snappy, high ventricular output state, low end diastolic volumes. That's a warm shock phenotype. In cold shock, we'll see really diminished systolic performance, as often that was the second echo that I showed with the heart that was barely squeezing. So we'll see lower ventricular outputs on both sides, particularly on the left side. We'll see low EFs. We see low fractional shortenings, low ventricular outputs. I think I already said that, sorry. And we don't see an empty left ventricle because actually the filling pressures are high. So they're often normal or maybe even big in size.
Yeah. Thank you. So that, yeah, I would use the same thing, just stroke volume. If it's really high, you're more likely to be warm shock. If it's really cold or really low, it's more likely to be cold shock. But there is some differentiation. Sometimes you need to do more than POCUS to get that. And I think your second question is about that as well. The arterial pulmonary hypertension, you already, explained the complexity. Can you capture that with ultrasound? Which one it is?
So pulmonary hypertension sepsis is so interesting because you cannot just use PDA right to left shunt as the diagnostic feature of pulmonary hypertension. Right to left shunt, first of all, a lot of these kids don't have PDAs anymore because they're older. But even if they do, PDA right to left physiology only tells you that pulmonary arterial pressure is higher than aortic pressure. But if you have a low SVR state and a normal PA pressure, that can actually drive a right to left shunt through the PDA. So that may or may not be the be all and end all of pulmonary hypertension. We will look at TR-jet, but TR-jet often doesn't exist in these kids if you have right ventricular dysfunction. We will look at septum flattening. But again, septal flattening can also happen if the left ventricle is empty because of preload reasons. So it becomes really complicated. A lot of times these babies are started on spec on nitric with presumed pulmonary hypertension with or without an echo. And a lot of times they are not nitric responsive. In fact, there's 2 studies that have looked at this, and most kids with late onset sepsis are not nitric responsive. So either that means that pulmonary arterial hypertension, not the primary physiology, that's probably what it means, or that inhaled nitric oxide isn't the right therapy. That's probably not the situation because our kids, when PAH is the diagnosis, they are INO responsive. So I think isolated pulmonary arterial hypertension without any other pulmonary vascular component being affected is not so common in sepsis because it's so multifactorial. I think it is probably reasonable to do a trial of inhaled nitric oxide if you don't have an echo because you have a baby in extremis. You might get a partial response, which is great. Then work on the other components. More likely you'll get no response, in which case think about alternative physiologies.
Ramoni is asking, can you tell a little bit more of this reduced heart rate variability during sepsis? Ooh, we might have lost her.
We
Uh,
don't use hero monitoring in our heart rate variability monitoring that oh can you hear me?
yeah, I can hear you now. Yeah.
Okay. I'm gonna move to a different part of my house to hopefully make that better. Um, so we don't use heart rate variability monitoring in our unit. The data on heart rate variability monitoring is that it can help you with this diagnosis of sepsis. So the units the available literature has shown that decreased heart rate variability is common in the early time period of sepsis. Once you have sepsis, can it help you identify shock? I'm not aware of any literature that has looked at that yet.
Hey, there's a question here about these non-invasive cardiac output monitors. They usually use impedance tomography or something like that. Do you have experience with that? Do they work? Do they not work?
Okay, so interesting. I looked at this a little while back. There's some NICOM data that has looked at the use of non-invasive cardiac output monitoring in other state, like for PDA and for other conditions, non-sepsis conditions, that have shown that it can be helpful in that it can correlate with echo features of cardiac output, but in isolation doesn't give you a number like how an echo would give you a number that you can actually apply to the baby. It's really better for trending. Problem with that in sepsis is that you only put it on when the kid is sick, so you don't know what the NICOM value was at baseline. So just putting it on when the baby's unwell doesn't really help you trend anything. So not enough data to guide use in sepsis. I think if we were to start using it, it'd have to be in a research capacity first because we don't know what to do with these numbers.
Samil has a question about cortisone, and it came into that flow diagram into warm shock. Do you use cortisone in cold shock?
Okay, it's so interesting. Um, Cold shock, I think, is one of the most interesting physiologies you see in the unit because if you actually see a baby with cold shock, you'll never forget it. They're so striking in terms of their clinical appearance. And what I have found, we get about one of these babies a year. I've never seen a baby start in cold shock and remain in cold shock, except one time. Usually they convert from their cold shock to their warm shock. It's like a very fluid, dynamic physiology. It's very interesting. Versus the warm shock babies tend to stay in warm shock. So why I'm telling you this is because by the time we have started our first line therapy for cold shock or inotropy, they often have converted into a different type of physiology. Would I use hydrocortisone to treat cardiac dysfunction in general? Yes, you can use it as a second line agent. But we tend to use it more in warm shock physiology because these are really inflamed kids. That's the warm shock phenotype, is lots of excessive inflammation. And that inflammation can cause endothelial destruction, like we talked about. And hydrocortisone, in addition to increasing receptor sensitivity to exogenous steroids, it also helps to maintain the endothelial integrity, like maintain those junctions intact to try to minimize that progression into SIRS. So certainly I'd use it in warm shock. And also you can use it for myocardial stability in cold shock as well.
There's a question here which is related, a standard neonatology is always related to, you target the third percentile of the blood pressure. In this particular scenario, particularly late onset sepsis, what do you target?
Great question. In late onset sepsis, because these kids are older, we have the benefit of knowing what the baby's baseline blood pressure is. So at the kind of early part of the talk, I presented two studies that looked at blood pressure changes in sepsis compared to the pre-illness, i.e. like pre-24 hours blood pressure. You know what the baby's baseline is. So you don't need to compare to population data of what third percentile is. Just look at what the baby's baseline blood pressure was 2 days before they got septic, and get an average ballpark. Our kids are often like have higher baseline blood pressures because of involving BPD, whatever it is. If you know the kid's baseline blood pressure is 80 on 50, targeting the third percentile of 50 on 30 doesn't make sense. It won't be enough. So really, we actually use the kids' kind of ballpark intrinsic baseline as the target for when we start vasopressors.
Yeah, totally echo that. You know what the blood pressure is. See, you can get near it. You don't have to be on it,
Yeah.
but get near to what the baby's average blood pressure was in the days before he got unwell. It's 1 o'clock. I got one more question. When you looked at shock and things and all the changes which is happening, and particularly in warm shock, what if you also have a large PDA? Does that make things worse?
Makes things annoying, that's for sure. Um, there's always the question about like how much blood flow from this PDA is contributing to the hypertension. Well, usually they've had their PDA from before that, and rarely do we see such in our unit, at least in Toronto for sure, do we see that these PDAs are so hemodynamically significant that they're causing shock. That's not the typical scenario that we see. So we do early screening. So we do screen and treat PDA within the first 3 days, and we do early symptomatic treating. So we are sites that treat PDA. This might be less applicable if you are conservative PDA tolerators. But if you do treat, we don't have kids that have chronic long-term exposure to ducts. But even if they are, that's not going to be a baby, or it shouldn't be a baby. The lactate of 9 and anuria, oliguria, and all those things that we talked about. So the PDA is probably not contributing to the hemodynamic phenotype. It can just make some of the characterization of pulmonary hypertension, like we talked about, a little bit difficult. A little bit difficult, yeah.
Well, I guess, it's like latest studies show there was more infection and more mortality in the babies with a PDA. So I was just wondering, this concept, if you have a PDA during a late onset sepsis, does it increase your mortality? Maybe it's a question we
Interesting.
should all delve in, a little bit deeper, because I think it's a thing, but I certainly have not enough data in my own clinic, but we should look at it together. Ashraf, this was fantastic. Thank you so much for staying up late and telling this fantastic, physiological and clinical talk. It was a really, really nice overview. Thank you so much. Thank you all for attending. I think we'll be back in 2 weeks with our next webinar. All right.
Thank you for having me. Thanks,
Thanks,
everyone.
Ashraf. Thanks.
Okay, good night.
Good night. I record and start our introduction. So, welcome everybody to another session of the Australian Neonatal Lectures. Today it is my great pleasure to introduce to you Dr. Adrian Bischoff. She's a neonatologist, from what I got originally from Brazil, but moved to Iowa and has been there now since 2019 as part of their faculty. And you can just notice that faculty has been certainly world leaders in creating, performing, and structuring neonatal hemodynamics in not only its understanding, but also in its training. And Aileen wrote a beautiful paper about this, and I asked her to, give us a presentation. How do you do that? Thank you.
Thank you, Kurt, for inviting me and for sharing some